Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Feldman, and I'm the chair and organizer of Grand Rounds, along with Leslie Crichton. I'm at home today, which is a part of the new normal that we're encouraged to work from home when we can. And it's raining, obviously. So Grand Rounds this week is delighted to welcome Rebecca Reynolds, who's Professor of Diabetes Endocrinology in Edinburgh. And she is here today to speak about gestational diabetes. She tells me in the preamble that this is part of the Insulin 100, which is the 100th anniversary of I'm not sure whether it's the discovery or the isolation or the manufacture of insulin, but she'll no doubt tell us, to highlight the role that Scottish scientists and medics play in diabetes research on a worldwide standpoint. And I think we're all very proud of our diabetes colleagues here in Dundee, particularly because we know we punch well above our weight in terms of diabetes research. So I'll hand over to Rebecca, who's going to give us a talk about gestational diabetes, of which I know very, very little, as it's way below the diaphragm. So I'm very grateful, Rebecca, if you want to share your slides just now, and we'll get cracking. Any questions, put them in the chat as usual, and I can ask them, or we can ping them out to individuals as we go along. Thanks very much, Rebecca.
Thank you very much, Tom. And I'm just going to put the slides onto screen share, which now means that I can't see any of you. So I'm sitting here in my house in Edinburgh as well, just talking to my computer, but hopefully they're on screen share. So thank you very much to Callum for asking me, and for Tom for organising this. I think I was supposed to be coming and speaking to you face-to-face last year, but obviously times have changed. So I'm going to talk about gestational diabetes, which is actually one of the most common complications of pregnancy. And our antenatal clinics are filled up with women with gestational diabetes, often crowding out our patients with existing pre-gestational type 1 or type 2 diabetes. But despite it being the most common pregnancy complication, we have an awful lot of uncertainty about how to manage it. But as you'll see when I go through my talk, because it impacts not only on the health of the mother, but also on the health of the child, then we've got huge opportunities to try and improve lifelong health for both women and their children. So what is gestational diabetes? Well, it was diagnosed, the classification was put together some time ago, and it's really defined as any degree of glucose intolerance with onset or first definition during pregnancy. So what that means is that even if somebody has a blood test during pregnancy which would suggest it's within the range of the threshold that we would normally diagnose diabetes outside of pregnancy, then we can't be confident in that diagnosis until we've managed to assess the woman when she's not pregnant. But obviously, if someone's got very high glucose in early pregnancy, then we think it's much more likely that they might have an underlying either impaired glucose tolerance, type 2 diabetes, potentially type 1 diabetes, or even MODY. As I say, it's the most common complication of pregnancy, affecting up to 25% of women across the world, depending on the threshold that you use for diagnosis and also the population in which you screen. But despite this, there's absolutely controversies at every stage of the way. And I'm going to talk about some of those today in my presentation. So we have controversies about when to screen, what test to use to screen, what thresholds to use of glucose to make a diagnosis, when's the best time to make the diagnosis, how should we treat women, what targets should we use for blood glucose monitoring, how often should we see women in the clinic, and how do we get women to come back for postpartum screening. So a lot of work for us to be doing. So why does gestational diabetes matter? Well, in the short term, it has several problems for the mother. I guess importantly, what it does is it medicalizes her pregnancy. She requires to have frequent hospital visits, sometimes as often as every fortnight or every month, and of course has to change her whole pregnancy in terms of her diet and her lifestyle, and also do regular glucose testing 4 times a day. So it changes the whole experience of the woman for being pregnant. In addition to that, and maybe partly because of all the monitoring that is done during pregnancy, and because we know that she's at increased risk of having a large baby, there's the potential for having an assisted or an instrumental delivery or a need for cesarean section, which of course increases length of stay in hospital. And all of this adds up to significant costs for the NHS. For the baby, there's also lots of short-term problems, and the most important one is the baby being born too large, having a condition called macrosomia, or large for gestational age, which typically means the baby's born over about 4 kilos or 4.5 kilos, depending on the definition. This can be associated with complications at birth, which include shoulder dystocia. Occasionally, the babies can also have problems with neonatal hypoglycemia, which means that they have to go to the neonatal unit. Again, because of the monitoring and concerns about glucose control in pregnancy, they're potentially having to be delivered early. And if gestational diabetes is not treated or not adequately treated, then there is an increased risk of the devastating complication of stillbirth. And it's now recognised that gestational diabetes, in addition to these short-term complications for both mother and baby, also has long-term consequences for both. So for the mother, the most important risk is an increased risk of type 2 diabetes. So data suggesting a 5 to 10-fold increased risk of developing type 2 diabetes. And this can occur within the first 5 to 10 years of being in the postpartum period, and is much more common in women who've had recurrent gestational diabetes. In addition to type 2 diabetes, women who have had gestational diabetes are at risk of developing what we call the metabolic syndrome, which includes this cluster of abnormalities, including things like hypertension, dyslipidemia, non-alcoholic fatty liver disease. And then there's some evidence that this whole inflammatory state is associated with other things, such as vascular dysfunction, chronic kidney disease, and in later life, ischemic heart disease. So if we can catch women early after they've had gestational diabetes and try and modify lifestyle factors, we may be able to prevent some of these chronic complications of gestational diabetes. For the child, there's also complications, and we know that children who are born to mothers with gestational diabetes are at increased risk of being obese themselves, and also developing the metabolic syndrome. There's obviously a lot less data on follow-up of children, so in terms of their age, but even in childhood and adolescence, there's evidence of dysregulation of glucose metabolism. And there's some evidence, although it's not entirely, it's not demonstrated to be causative, that there may be some potential problems with ADHD and autism spectrum disorders in children who were exposed to high glucose levels in pregnancy. And why does gestational diabetes cause this problem? Well, I guess the best data to show the relationship between glucose and adverse outcomes of being born too large, so being born above the 90th percentile, is data from the very large HAPO study, which was a study of around 35,000 women who underwent a glucose tolerance test. This was women from across several different countries. They had a fasting glucose. They then had the 75-gram oral glucose challenge, and then had blood tests done at 1 hour and at 2 hours. And what you can see on the graph on the left is the relationship between the glucose levels and the frequency of having a baby that's born too large. And what you can see is that there's a direct linear association. So that those women who have higher glucose levels, whether it's fasting glucose or higher glucose levels post the glucose challenge, are the ones who have the largest babies. And coupled with that, there's an increased risk of cesarean section in women who have the highest glucose levels. And so we know that diabetes in pregnancy really acts as this growth factor to increase fetal growth. And that's partly because even in a normal pregnancy, insulin sensitivity decreases as the pregnancy progresses, and women become more and more insulin resistant. And the reason for this is then to release fuels, including glucose, non-esterified fatty acids, lipids, and amino acids, which are, of course, are all fuel for the baby, and these can cross through the placenta. And then what they'll do is they'll drive the fetal pancreas to produce insulin. And of course, we know that insulin is a growth factor. And if these maternal levels of glucose and other biochemical markers are too high, then this can lead to increased fetal growth and macrosomia. So who's at risk of gestational diabetes? Well, we know quite well that there's several high risk groups of women. And of course, this is one of the reasons why there's so many women that we see with gestational diabetes, because one of the key risk factors is a high BMI. So having a body mass index of over 30, if you're from a white Caucasian population, but a lower BMI, so around BMI 26 or 27, if you're from a high risk ethnic group. Other risk factors include having a previous large baby, having previous gestational diabetes, family history of diabetes, certain ethnic populations, particularly Southeast Asians, polyhydramnios and glycosuria, and also having a baby that's, as I say, previously been too large. And so what we recommend in this country is that anybody who's high risk should be screened for gestational diabetes. But you'll already realise that with the very high rates of BMI, so the increased prevalence of obesity, this means that actually almost half the population already of women that are pregnant potentially might need to be screened for this condition. And of course, the prevalence of gestational diabetes is rising with the rising prevalence of obesity and rise in maternal age. And so currently in the UK, there's no ability to do what we call universal screening, which is just to screen every single woman, and we break it down into these high-risk groups. So just to say a little bit more about the rising prevalence of obesity amongst pregnant women. So while there's obviously an epidemic of obesity amongst all individuals, this is really quite dramatically a problem among young women of reproductive age. This study from 2017, including 1.3 million pregnant women, indicated that 3 out of 4 pregnant women worldwide had a problem with excess weight, and they indicated that this was potentially leading to preventable adverse outcomes for both women and their babies. And in Scotland, we've got the highest rates of obesity amongst adolescent girls in the whole of Europe, and of course these girls will be the next generation of pregnant women. So that's already a risk factor for gestational diabetes. And the problem with obesity is that it kind of compounds the risk of gestational diabetes on birth weight. So this is quite old data, but again, it's looking at the odds ratio of having a baby that's born too large, so above the 90th percentile. And you can see that compared with the babies who are born to normal weight women, then the risk of having a large gestational age baby, if you have gestational diabetes, is around a 2-fold risk, slightly similar increase if you are born to an obese mother. But if the mother has both obesity and gestational diabetes, there's an increased risk of nearly 3.6-fold increased risk of having a large baby. So clearly this is a problem, and it's a particular problem for us in Scotland. So how do we make the diagnosis? Well, this is where we enter into one of our controversies or uncertainties, and that is to do with the different screening criteria. And really this is because of that graph that I showed you of the continuous inverse relationship between glucose and having a large baby. And unlike other problems in diabetes, there's no inflection point where the risk suddenly increases. It is a continuous relationship, and you really have to try and pick a cutoff that you think is going to have the best outcome for the most individuals. So in Scotland, we use the current SIGN guidelines, which are based on the IAD-PSG, which is the International Association of Diabetes in Pregnancy Study Group. And what that recommends is that either all women or high-risk women, and in Scotland, we just focus on high-risk women, have a glucose tolerance test with cutoffs of a fasting glucose of 5.1 and a 2-hour value of 8.5. The SIGN guidelines are actually currently really out of date because they were published in 2010. And I'm on a panel where we were reviewing all the SIGN guidelines and updating the pregnancy guideline. And we had to put everything on hold due to COVID because the team that worked with SIGN were busy working on COVID. So that's currently suspended, but I think we're planning to get started back on that again. By comparison, so I should say the SIGN guideline of a fasting and a 2-hour is the same as the WHO recommendations. But in comparison, in England, they use the NICE guideline, which was published in 2015, but then was updated in December 2020. And for them, the cutoff is completely different. So a fasting glucose of 5.6 compared with 5.1, and a 2-hour value of greater than or equal to 7.8 compared to 8.5. So you can see that depending on where you live in the UK, and depending on what your fasting glucose or 2-hour glucose is, you may or may not be diagnosed with gestational diabetes. And of course, that creates a lot of issues for people who are travelling between England and Scotland. But at the moment, we're using the lower fasting glucose cutoff. So the other controversy is whether we are diagnosing gestational diabetes too late. We currently do our glucose tolerance test at between 24 and 28 weeks gestation. But there's an increase in literature to suggest that maybe this may be too late, and that maybe there may be opportunities to diagnose gestational diabetes earlier in pregnancy and see whether treatment improves outcomes. This study that was published last year suggested that even if women are diagnosed early with gestational diabetes and treated, they still have adverse pregnancy outcomes. And the reason for that might be that actually we're doing a diagnostic test for gestational diabetes at 24 to 28 weeks gestation, but we know that the fetal growth trajectory is already very well established before that window of gestation when we make the diagnosis. In this study that was conducted from the Cambridge group in their POPs pregnancy outcome prediction study, they looked at ultrasound scans of women who'd had their 20-week ultrasound scan, and then they went on then to look at the data to see who had either gestational diabetes or who was obese. And they could already see that the women who turned out to have gestational diabetes diagnosed at 24 to 28 weeks gestation, you could already see at 20 weeks gestation that their babies already had an abdominal circumference that was greater than the 90th percentile. So maybe us diagnosing at 24 to 28 weeks, we've kind of missed the boat, and we should be thinking about earlier diagnosis. So there's an ongoing trial in Australia called the Toboggan trial, where they're randomizing women to early screening for gestational diabetes, and then they're revealing half of the outcomes. And if the women have a diagnosis of early gestational diabetes, they're treating them. And then the other group, they keep the results concealed and then reveal them at 24 to 28 weeks, and then do a glucose tolerance test at that stage. And the very pilot data, maybe of concern, shows that actually those women who are being diagnosed early and treated early, then there's possibility that there's some over-treatment going on, because there's been more admissions to the neonatal unit with small for gestational age. Whereas in the women who they didn't treat the early high glucose, but waited to do the treatment at 24 to 28 weeks, there's a slightly higher rate of large for gestational age. So these trial results are coming out later this year, and we're very much looking forward to seeing what they show. Although, of course, the population in Australia is very different, including particularly a very high number of Chinese women who develop gestational diabetes at much lower BMI rates. So the findings may not be directly applicable to our Scottish population. Nevertheless, the James Lind Alliance, which has recently, over the last couple of years, been running a priority setting partnership exercise to identify the top research priorities identified by both women and health professionals for diabetes in pregnancy. The number one test, well, it was a joint number one priority, was what is the best test to diagnose diabetes in pregnant women. And that's due to the uncertainty about the time of diagnosis and whether the glucose tolerance test is really the best test that we should be using, whether we could be more clever with our way of diagnosing diabetes in pregnancy. So if we have made a diagnosis, albeit it might be different depending on where you live in the country, then the one thing where there is consensus is that women who have gestational diabetes should be managed by a multidisciplinary team. And that includes a team which includes not only midwives and diabetes specialist nurses, but also essentially a dietitian, and then the input from consultant obstetrics and diabetology. And we have, within Scotland, we have very good multidisciplinary teams who manage women with gestational diabetes. The first line of treatment is lifestyle intervention, which predominantly will be making changes to diet and then potentially asking women to increase their physical activity where possible, although this can become increasingly challenging as pregnancy progresses. There has been interest, however, in whether we're giving the best approach for diets, and it might be that we just need more research on this. And indeed, in that James Lind Alliance priority setting partnership that I highlighted, the number 3 research priority that was identified was what is the best way to manage blood sugar levels using diet and lifestyle during pregnancy. Dietitians currently use a very traditional approach that they would be using for guiding people with type 2 diabetes about restricting carbohydrates and using the Eat Well plate. But there is some interest in as to whether less carbohydrate restrictive approaches might be suitable for women. There's also questions from women about whether they might be able to follow low glycemic index diets, whether there might be any use of using dietary supplements such as myo-inositol, although to date the data do not look particularly convincing. But importantly, it's recognised that for any dietary approach that's being taken in pregnancy, there needs to be consideration for not only the outcomes from pregnancy, but also the longer term outcomes for the mother and the child. Because of course, I've already told you that this condition is increasing the risk of type 2 diabetes. So maybe if you can adopt a healthy approach to diet during pregnancy, that might be able to be maintained into the postpartum period. So what next after lifestyle? Well, it's some time ago, over 15 years ago, that a choice study was published, which suggested that reducing maternal glucose in pregnancy improved outcomes from gestational diabetes. So they looked at women who had impaired glucose tolerance in pregnancy and randomized them to routine care or a dietary intervention plus or minus insulin. And they demonstrated that the adverse perinatal outcomes were lower in those who had received the treatment intervention with diet and insulin compared with those who had routine care. So we know that if we can control glucose, we should have better outcomes. But I guess when we're considering what treatments we want to give, we need to think about who are we actually intervening here? Are we intervening to improve outcomes for the mother or the child? And how can we get a balance that might actually have benefits for both? For the mother, we might want to think about things like convenience, tolerability of drugs, maybe options that don't cause gestational weight gain or excessive gestational weight gain, options that might put the mother then in a better health for her next pregnancy and potentially improve her risks postpartum, including risk of later life obesity and type 2 diabetes. And for the child, we want to have a drug that will certainly have no short-term outcomes, such as any teratogenic effects or any adverse effects on birth weight, but also something that we think doesn't have any potential long-term adverse effects. And of course, with any drug in pregnancy, there's a very limited kind of desire to test out new treatments. And so we actually have a very limited choice of what we can use if dietary measures have failed for treating GDM. So the landmark study that was published over 12 years ago now was called the MIG trial, which was the metformin versus insulin for the treatment of gestational diabetes. And it was run from Janet Rowan in New Zealand with colleagues in Australia. In this study, they randomized 751 women with gestational diabetes to either metformin and then insulin added in if they needed it, or insulin. And of course, metformin is a drug that we use very routinely in our standard diabetes clinics. It's an insulin sensitizer, and it's a tablet. And so the idea was that maybe this drug would be also good for lowering glucose in pregnancy. And because it's a tablet, it's easier for women to take and doesn't require a diabetes specialist nurse to show someone how to administer insulin. And they had a composite primary outcome, as is very common in these trials, where there's a balance of trying to find out benefits for both the mother and the child. So when they looked at their primary outcome, which was the difference between outcomes in women who'd been exposed to metformin plus or minus insulin or insulin alone, there was absolutely no difference. So I guess what that shows us that metformin was not inferior to just the insulin treatment. And then when they looked at their secondary outcomes, they found that the women who'd been treated with metformin plus insulin had significantly less gestational weight gain than those with insulin, which of course could be viewed as a positive outcome for the women. And so really, because of a result of this trial and the fact that there were no adverse effects, then metformin has become a drug of choice that we use in treating gestational diabetes, particularly in the UK, where it's endorsed by both NICE and SIGN guidelines. However, metformin is not used everywhere. In particular, in the States, they are concerned about potential effects of metformin, which I'll discuss in a minute. And they rather use a drug called glyburide, which we know in the UK as glibenclamide, which is a very old-fashioned sulfonylurea. And we don't use it at all in our routine diabetes clinics because it has potential huge risk of hypoglycemia. And then the other option is insulin. And there's a large number of people around the world who do not feel confident about either metformin or glibenclamide, and so will offer insulin as a standard treatment for women as their first-line treatment because of concerns about longer-term safety of exposure to either metformin or glibenclamide. There has been some work to think about how we can predict which women might respond best to which treatment, but so far the potential predictors are not particularly informative, and so we tend to have a bit of a one-size-fits-all approach. And certainly in our clinics, where many of our women are obese and overweight, we would certainly offer them metformin in the first line, and then if they don't tolerate it or their glucose levels don't improve, then we would add in insulin. And of course, things like being older, being obese, having previous gestational diabetes, having diagnosis of gestational diabetes earlier in gestation, glucose levels being higher, are potentially factors that might mean that women are more likely to need insulin during their pregnancy, in addition to metformin, or if metformin is not tolerated. But I guess also, as we're trying to move a little bit more towards thinking about not just a one-size-fits-all, but thinking about being more, I guess, moving to more a precision medicine approach, where we're trying to think about what's the best treatment for this particular woman, then there may be other angles that we can think about to help guide us as to which drug to give. So, for example, with metformin, the metformin has been quite widely used now in a number of studies, both in studies of type 2 diabetes, gestational diabetes, and in women, of course, who have polycystic ovary syndrome, who may be taking metformin prior to pregnancy. And there's some evidence from trials that metformin does lower the risk of preeclampsia. And so maybe that might be an added benefit of using metformin during pregnancy. Another thing is we might think about the harms of drugs. And I've already mentioned that glibenclamide is a drug that we don't even use in the UK in our standard diabetes clinics, and that's largely because of risk of hypoglycemia. And there is some evidence from trials that this also causes an increased risk in neonatal hypoglycemia. And it may be also partly because there's a very limited range of dosing options that you can use, so it's hard to use very tiny doses. We also know that our choice of drug and our need for treatment can really depend on how we monitor the woman's glucose during pregnancy. We currently recommend glucose monitoring 4 times a day, but even around the country, there's variations in whether women measure preprandial, so before eating glucose levels, or postprandial glucose levels. And this can really change your need for therapy. So in Edinburgh, we did a period of time where we swapped from preprandial measurements to postprandial measurements. And the main outcome was that significantly more women went on to insulin with no difference in any of the other outcomes. So even things like when you test your blood sugar might make a difference. And of course, with new ways of monitoring glucose, such as flash glucose monitoring, then it's possible that we're going to have even more information about how to monitor glucose. And then we need to think about the potential long-term effects. So there's quite a lot of controversy going on about whether metformin is truly safe in pregnancy. That's not because of any risk of teratogenicity, where it's been shown quite clearly that actually there's no increased risk of adverse congenital abnormalities, but there is concern about any potential long-term effects for the child. And this is because metformin crosses the placenta, and the transporters for metformin are present in the placenta, and we know from measurements of maternal and cord blood levels that the cord blood levels of metformin are at least as high as they are in the mother. There's limited follow-up data, largely from trials that were designed to look at short-term outcomes, and so of course are likely to be subject to the usual biases of loss to follow-up. But there's accumulating data where it's been possible to look at some of the cardiometabolic outcomes of women's children who are exposed to metformin in utero. One of the largest studies is looking at the effect of metformin on birth weight, and in this meta-analysis, which was done by colleagues in Cambridge, they showed that women whose children were exposed to metformin had a lower birth weight than those who were not exposed to metformin. Of concern, when they've looked at the follow-up, and albeit this is a fairly small number of individuals, there was a small but significant increase in BMI at age of 5 to 9 in children who had been exposed to metformin in utero. And so with this combination of the low birth weight at suggesting that there may have been some fetal growth restriction, this is then associated with the higher BMI, suggesting that there may be early catch-up growth, which we know from other larger studies is associated with increased propensity to obesity and cardiovascular disease in older life. So this is why there's some concern about using metformin in terms of long-term outcomes for the child. And of course, we know that we're in the midst of a crisis where there are a record number of severely obese children. And so as gestational diabetes itself predisposes to obesity, we really do want to be avoiding drugs that might be exacerbating that problem. And this is particularly important because we know that if you have high BMI in early childhood and into adolescence, then there's an increased risk of sustained obesity and all the consequences of adverse health that come with that. And so this is something that we really need to think carefully about in deciding who's the best person to get metformin if they have gestational diabetes in pregnancy. So for the last part of the talk, I just really want to tell you a little bit about gestational diabetes and COVID. And you're probably thinking, oh, this is the last thing I want to hear about. But actually, I think it's important to highlight because COVID has really impacted on the way that we diagnose and treat gestational diabetes. And a lot of that has really almost made all these uncertainties that I've spoken to you about, the timing of diagnosis, what tests to use and how to monitor people, has really made it much more alive and made people realize that we really are dealing with a management problem. So when the COVID pandemic hit, then very early in March, just around the time of the first lockdown, the Royal College of Obstetricians and Gynecologists published a guidance for management of pregnant women, and that included guidance about how to manage gestational diabetes. And the reason for this is because women were considered to be a vulnerable group, largely due to knowledge of what had happened with other coronaviruses. And so women were encouraged to stay at home as much as possible. And the guidance for management of gestational diabetes was designed to avoid as much face-to-face contact and unnecessary trips to the hospital as possible. So one of the key things that was recommended was to stop doing oral glucose tolerance tests, because of course somebody has to go to a hospital or a community centre, have a fasting glucose, drink the glucose challenge, and then have a blood test 2 hours later. And so that was really recommended not to do. It was also recommended that people should have more remote monitoring with virtual clinics. And also even the cutoff or the threshold that we use for diagnosing gestational diabetes was recommended to be different, largely because we weren't using the glucose tolerance test. So this led to very rapid and significant changes in care delivery of gestational diabetes across the UK. And while the authors of the guideline had obviously tried to pull together as much evidence as they could to underpin these recommendations, it was really done with very little evidence. And as I mentioned before, if we don't treat gestational diabetes and if we miss women with gestational diabetes, there's a significant increased risk of stillbirth. And so there's been some concern as to whether these changes were really necessary and what the potential impact might be. So there's been very few data published so far, and I guess that's partly because of the time that it takes for women to be diagnosed with gestational diabetes and then complete their pregnancy and then collect the outcomes. So there's one small study that was published from London very early on, only 35 women, saying that during that period of time they'd got a 45% reduction in their levels of gestational diabetes. A similar kind of study came out from Australia, which suggested, again, dramatic reduction in number of women being diagnosed. And then people have used retrospective data to try and model what these changes might mean to the prevalence. So using that very large database that I talked to you about, the HAPO database, they suggested that there would again be a very big reduction in gestational diabetes prevalence, from falling from 17% down to 2.5%. And that the people who had been missed would be having higher rates of macrosomia, cesarean delivery, and preterm birth. So we decided that this was a good opportunity to try and do a more prospective study. We're part of a diabetes in pregnancy clinical studies group, which includes representation across the UK. And so what we're aiming to do is to use this natural experiment afforded by the changes in GDM care by the COVID pandemic to look at outcomes from women during this time and to understand the impact of these on obstetric and neonatal outcomes in the maternity population. So we've been going through the processes of getting all the ethical and regulatory approvals, which are now in place, and all the sites are collecting their data. I thought I'd just share with you some of our preliminary Lothian data, which is still not complete because not all the women have delivered their babies yet. So we have a database of all our women with gestational diabetes in Lothian. And what we did was we picked women from 1st of April 2020, this is the orange column, up until December 2020. And then because there's a known a seasonal component to diagnosis of gestational diabetes, we had a matched time period from 2019. We excluded, obviously, women who had miscarriages or multiple pregnancies, collected the data from the healthcare records, and as I say, not all of our women who were pregnant we've got outcome data for, although that's coming. So we've got outcome data for 174 women of the pre-COVID group and from 115 women from the COVID group. This slide looks like it might have shifted a bit, but it basically shows the demographics of our two different populations. And the long and the short of it is that there's no particular difference between the pre-COVID demographics and the COVID demographics. So we don't appear to be diagnosing different women according to demographics like their age and their BMI and their ethnicity and social class. What about the prevalence of gestational diabetes? Well, the blue bars show the pre-COVID cohort and the orange bars show the COVID cohort, and the top graph shows the GDM cases by month. And what you can see, in addition to the seasonal effect of gestational diabetes, is that there's always more people diagnosed in the blue bars than in the orange bars. Of course, we were worried that that might just be that there were maybe less women getting pregnant over the COVID times, but if we look at our antenatal booking in Lothian across that time, there's absolutely no difference. And so what we have seen is a 19% decrease in our number of GDM cases during that period of time between April and December 2020, when our guideline for managing gestational diabetes was changed. What about outcomes? Well, if we look at our diabetes, how did we diagnose gestational diabetes? Then there was no difference in the gestation at which they were diagnosed, but we have diagnosed women with a slightly higher fasting glucose. So glucose of 5.4 compared with a glucose of 5.1. But despite that slightly higher fasting glucose, no difference in the number of women who needed to be treated with diet, metformin, or insulin. And if we look at the maternal outcomes, including complications at delivery, mode of delivery, and pregnancy complications, then we see no difference at all between either the pre-COVID and the COVID group. And then when we look at our neonatal outcomes, again, we see virtually no differences. So no differences in gestation at delivery or birth weight, but we do see a very small change with an increased risk of shoulder dystocia, the complication which is associated with gestational diabetes in women from our so-called COVID cohort. As I say, the numbers are not yet complete, and this is very preliminary data. You'll also notice that there's actually a slightly higher percentage of women who have a higher birth weight baby, although that obviously doesn't reach statistical significance with this small group. So maybe as we increase our sample size, we might see some changes there. So we've got a 19% decrease in gestational diabetes, and we don't think that's just due to a change in birth rates. And we did have a slightly higher fasting glucose in women who were screened at 24 to 28 weeks gestation. So does that mean that maybe we have actually not been screening so many people, not been screening women maybe who have a BMI of 30, or 29, who've just missed out on the screening? Or have we missed women who have a higher 2-hour value because we weren't doing a glucose tolerance test? We need to do more investigation into understanding that. As we increase our sample size, we do have a bit of concern that we might see some differences in outcomes. So potentially in increased number of babies born larger. And again, we don't know whether that's because we're diagnosing a different population. So women who have worse glucose tolerance at their diagnosis with higher glucoses and therefore more likely to have a big baby, or is it due to a change in our way of monitoring people through remote clinics? Although it doesn't appear that our treatment interventions have changed. And again, of concern, more women had shoulder dystocia, which is, as I say, a complication of gestational diabetes and often associated with babies that are slightly larger. So what are we doing next? Well, we're expanding our pre-COVID cohort in Lothian. We've got data going back for the last 5 years, so around 1,000 women, which will make us have a much more confident data set. And we've obviously got the outcomes of those pregnancies still to collect. And then we're in the process of gathering data from around 9 other sites around the UK, which will give us around 10,000 cases of gestational diabetes and a lot more statistical power. So far, we're only collecting from Edinburgh and Glasgow, but if anyone's got data from Dundee who wishes to come on board, we'd be really keen to add some numbers to our study. And in order to help us interpret the data, we're conducting a qualitative exploration, capturing the views and experiences of healthcare professionals who've been delivering care to women with gestational diabetes both before and during the pandemic. So I guess what we're trying to do here in managing gestational diabetes is to really try and break this so-called intergenerational cycle of obesity and diabetes, where we have a woman who is at risk of gestational diabetes during pregnancy, develops gestational diabetes, which then exposes her fetus to an abnormal metabolic environment. The baby's born large, and then without treatment would potentially develop obesity in childhood and then into adulthood and continue this cycle. And I think the opportunity we have for gestational diabetes is to really try and interrupt this cycle and improve the health of both the mother and the child. And this is where the Scottish Diabetes Type 2 Diabetes Prevention Framework comes into place, where there's this big campaign across Scotland to try and identify those people who are at most risk of type 2 diabetes and really put in place very good and consistent dietary interventions to help prevent future type 2 diabetes. And women with gestational diabetes are being targeted as one of those high-risk groups and being encouraged to enter into dietetic programs to help reduce their risk of type 2 diabetes. And we're really looking forward to seeing how this evolves over time and hopefully improves our detection rate of type 2 diabetes as well, which is very poor at the moment. So I hope I've convinced you that there's lots of uncertainties in managing gestational diabetes, but also lots of opportunities for us to improve outcomes. We've still got lots of questions to ask: when to screen women, what tests to use, which glucose thresholds for diagnosis, how we should treat women, what are the targets for glucose monitoring. I haven't discussed the controversies in obstetric management because I'm not an obstetrician, but there's lots of controversies about how best to monitor women, whether with ultrasounds and CTGs, etc. How do we encourage women to have postpartum screening, and how do we improve the long-term health for the mother and the child? And we have written a summary document which was published last year in the Lancet Diabetes and Endocrinology, which will give you more information. But otherwise, I'd like to thank you all for listening. Thanks to Niamh McLennan, who's my clinical research fellow, who's working with the Diabetes in Pregnancy Clinical Studies Group on the COVID work, and also many thanks to the funders. Thank you. I'm happy to take any questions.
Thanks very much, Rebecca. That's really fascinating stuff. Looking at the participant list, it's drifted up to 49 as the late stragglers came in. We've got obstetricians, we've got diabetologists, and lots of academics. So I'm sure there'll be some questions here. Now, Callum is asking a question about sputum. I think that's a typo. So we'll maybe pass over to him to ask him if he can ask his question in person.
Yeah, sorry, I meant postpartum, not postsputum. It's
I'm touched that,
yes.
that you're thinking about sputum.
Yeah, I was wondering if the women have been on metformin, has anybody done a study where they continue the metformin and see if that affects incidence of type 2 diabetes?
Yes, so there's a study going on at the moment in London. I'm actually on their trial steering committee, so I can't really tell you the outcomes, but what they're doing is they're recruiting women who have been taking metformin during pregnancy, and then they're asking them to continue their metformin for a year afterwards and looking at the outcomes of rates of type 2. So that the results are available, but they're obviously, I can't tell you what they are. So they will be publishing those hopefully soon.
Okay, Tony Nichol, one of our obstetricians, who specialises in the complex maternal health. Tony, do you want to ask your question in person?
Yes.
Or are you too shy?
Thank you very much for that really interesting talk. I very much enjoyed it. I'm, as Tom said, I'm an obstetrician. I look after women with high-risk pregnancies. It's one of my colleagues that runs the obstetric side of the diabetes service, but we do refer our patients or women to her. It is interesting. I work on the labour ward, and we have seen, my feeling is that we are seeing bigger babies in the last few months, and I do wonder if that reflects the experience that you're having in Lothian. I don't have our local data, but I'm sure we'd be happy to look at that and share that with you. My question, the thing that caught my attention was when you talked about metformin and reducing preeclampsia risk, and I just wondered if that data was from the diabetic population, or if we can apply that to our general obstetric population, if there's any evidence to support that.
Yeah, so thank you for the question, and also thank you. Would be really keen if you've got someone who can help get some data for us. So the data on preeclampsia comes from 2 trials which have looked at giving metformin to obese pregnant women who don't have diabetes. One is our own trial from Edinburgh called Empower, and the other is a trial from London called the MOP study. So it's data on around 1,000 women who are obese who are randomised to metformin versus placebo, and in the aggregate data there's a lower risk of preeclampsia. It's quite preliminary data, but it's certainly something that is sort of gaining interest. And but I guess the bottom line is that the metformin so far doesn't do much in terms of improving other outcomes, and so I think it's not going to be, especially as we're giving women aspirin now, I think it's probably not going to be much over and above the aspirin.
Okay, thank you for that. It's really interesting.
Okay, there's a first timer here called Ewan Pearson, probably wants to learn a little bit about diabetes, so we'll pass over to him, see what he has to say.
Thanks. For some reason, my video is not working. Thank you, Rebecca. Fantastic talk. I obviously obsessed around metformin and hadn't seen the data around the potential adverse effects of metformin, which I think was really interesting. So there's an obvious potential study to do, which is to look at the genetic variants in the transporters at the placenta, which would give you a really nice way of knowing whether that metformin getting into the fetal circulation is harmful. So maybe we should talk about that another time, but it all depends on how many mums we have where we have genetic data, but there's quite large populations around now, and metformin's been used for a long time. So I think that would be good to do. So it's more of a comment, I suppose, and a question. And as you know, I think metformin really works in the gut rather than anywhere else. So presumably these slow release, delayed release, non-absorbed forms of metformin may be something to consider.
Yeah, so thank you, Ewan. So, I mean, we've been trying to look for we've been looking at placenta from our women who participated in this trial, which I mentioned, which was obese women without diabetes who took metformin versus placebo. And we've done quite detailed RNA and DNA methylation arrays and RNA arrays, and find absolutely no difference at all between the two. But we haven't particularly drilled down in the transporters, and I think that's something that we would be really interested in doing. Sorry, the other question was
the delayed release.
Delayed release, yeah. So the delayed release is something that we're actually actively working on at the moment, because, like you, we were thinking that maybe the delayed release would be a way to get around this this passage across the placenta, because this is all driven by the transfer gradient between the maternal levels and going across the placenta. But actually, when you look at the pharmacokinetic data of the currently available delayed release preparations, they still result in a peak plasma glucose levels. So we're exploring another formulation, which is currently just in early phase trials, as to whether that might be possible to avoid that high peak in the mother.
That's the one I was thinking of, Rebecca. Yeah. There's one that's essentially not absorbed systemically.
Exactly. The one that's been used in renal failure.
Yeah.
Yeah. We're on the case.
Ros, I'm not sure which Ros. Ros has said, we've started looking at our own local data, happy to join the Lothian team. So that's an offer of reaching out over the Tay to join together. From one diabetes expert to another, we'll go on to Rory McCrimmon.
Hi, Rebecca. Good to see you. Thanks for the talk. Great talk. I thought I'd better rescue you from the pharmacogenomics talks, which I just knew you were going to get. Move on slightly more practical basis. I mean, what COVID has also taught us about the virtue of virtual clinics and assessment. I just want to know what your experience is, and how much, now that we can use continuous glucose monitoring, do you see in terms of the future of the management of diabetes pregnancies and GDM in that space? And then I guess moving on from that is around long-term management. It very clearly is a marker for long-term risk of type 2 diabetes. And are we getting it right in terms of our strategies around obesity and weight management and follow-up, etc.? Just get your thoughts on that would be great.
Yeah, so in terms of the virtual clinics, I think we already had a virtual clinic in Edinburgh before COVID, but it's been far more utilised during COVID. And I guess for some women, it works really well. They don't have to travel to the hospital. They can be followed up, those people who would miss appointments. But what it's done is it's just placed the burden onto our diabetes specialist nurses. And it's sometimes really difficult to titrate therapies when you're not looking at someone in the eye to understand whether they're really taking something. So I think we've still got something to learn about it. And that's, I guess, partly why we're doing this qualitative work, because if we interview women, then we find that they like it. But if we interview healthcare professionals, there's a huge mixed understanding. And currently for gestational diabetes, we don't use flash glucose monitoring unless we've got someone who really doesn't like pricking their finger. And so we're still reliant on, but we have got obviously the facilities now to Bluetooth glucose values back, and we can have a much more regular assessment with people rather than looking at their blood-stained diaries. So I think what it's highlighted to us is that we need to have much more support for our diabetes specialist nurse team, and much more structured systems in place so that we know who to bring back to the clinic and when. In terms of the postpartum monitoring, I think we've got this really not well organized. We ask women to come back at a time when they've got a young baby, when they're trying to juggle lots of things. We know that actually the pickup rate at that time is quite low. We can probably be better during pregnancy at highlighting who we think really needs to come back. I think what is good is our GPs are very good at doing kind of testing just on the hoof if somebody turns up for something else. Certainly our audit data from Edinburgh suggests that we get a lot of pickup with that. But I think we need a huge amount of education to make women realise they are at risk and they do need follow-up. They're very good at being followed up during pregnancy, where they're concentrating on their child, but once the child has arrived, their priorities change. And I guess that's where the diabetes prevention programme can maybe hopefully really helpfully support these women and make them realise that they need to think about their own health and preparing for their next pregnancy as well.
Great, thank you.
Right, thanks very much for that. Does anyone else have any more questions? I'm just scanning. Rory's hand is a legacy hand, I think. And no other hands, no other questions.
Hi,
Rebecca,
I have a question. Sorry, I can't get my hand
Ross
up.
has a question. No?
Sorry. Hello, hi, Rebecca. Thank you so much for the talk, and I appreciate Tom having this talk on obstetrics. I run jointly with my colleague, the diabetes service in Perth. I'm not sure whether we've met before, but thank you so much. I mean, one of the things which we did, I think when we started our screening for diabetes within COVID, I think, Pauline Lynch is here as well. We had a huge discussion about, the college guideline, and what we decided to reduce, missing women was to stick with 5.1 as our fasting glucose. So we never raised it. So Priya George is the diabetologist in Ninewell. So we had already started collecting our data, because obviously we needed to show what we had done. But we're happy to obviously share that data with you, because I suppose our threshold remained at 5.1 for the fasting.
Yeah,
so,
well, I mean, we did the same in Edinburgh, so we were 5.1 before, so we didn't go up to 5.3, but I think, the English sites have changed. The ones that were 5.6 did go to 5.3 and then saw their numbers go up. So I think it's going to be different depending on where you live.
Yeah, great.
That would be great.
So much.
Thank you.
Thank you.
Okay, right. Well, thanks very much for everyone's input. And thanks again to Rebecca for joining us. We're sorry that we couldn't see you face to face last year, but it's been great to hear from you now. And hopefully you'll consider coming back at a later point with more results of more of those studies that you had to keep stum about. Next week, our grand round is about human trafficking, the hidden truth about human trafficking in Scotland. So that's going to be a fascinating talk, which has been organised through the global health part of grand rounds. So I hope you do tune into that. Remember that you can watch all the grand rounds, well, most of them back to about 2015 by logging onto our YouTube channel, which you can find just by searching Dundee Grand Rounds. Remember to like, subscribe, and then click on the wee bell for the notifications. And that's everything for me. Enjoy the rest of your day and your weekend, and I'll see you again next week. Thanks very much again, Rebecca.
Thank you. Bye.